vaccines and the public health value of rotavirus vaccines. Really nice talk, I think.
In advance, you know what I'm talking. Well, first, I'm sure I'm sure people are excited that we are almost at the end of the day. It's been
So
a
Umesh will take us home straight to dinner.
I promise I'll stay in time, or maybe even make a couple of minutes. But it's been a fascinating day. I think great talks, and I've learned a lot. What I'll try to do in the next 20 minutes is really talk about the post-licensure data that has been obtained over the past decade. We've had 2 rotavirus vaccines that are in use globally, and really try to illustrate how that experience that we've seen post-vaccine introduction has really expanded what we knew about the vaccines from the data gathered during clinical trials, to really illustrate why we need this post-introduction monitoring to appreciate the full public health value of a vaccine. As I mentioned, we had 2 vaccines that were licensed about a decade ago. They went through these 2 large clinical trials. They were big trials, really, 60 to 70,000 infants in each of these trials conducted in the US, Europe, Latin America. And they were large of this magnitude to look at an adverse event intussusception, which had led to the withdrawal of an earlier rotavirus vaccine in the US. And the good news from these trials was there was no increased risk of intussusception seen in these large studies. The trials also showed that both vaccines had very good efficacy against the outcome of severe rotavirus gastroenteritis that was measured. You can see anywhere ranging from 85% to 98% efficacy for each of these 2 vaccines, at least in these initial trials in high and middle income countries. The vaccines, as I mentioned, are now broadly rolling out. There are 81 countries around the world that use these vaccines in their national immunization programs. You can see the countries shaded there. The dark blue ones are the rich middle income countries, and the ones in green are Gavi eligible low income countries. So we are also seeing very large introductions in these low income settings, which is very exciting as well. The first question that obviously comes to mind, trials are done under ideal conditions and everything is set up well. In routine immunization programs, sometimes things don't work so well. So you want to see how the vaccines perform in routine use compared to what was seen in the trials. And I'll show you data from the US, which is a setting where we've had 10 years of vaccine use now, and both the vaccines are recommended for vaccination of US infants. And you can see this is a summary of 5 different studies that have been done using case control methodology predominantly to look at the field effectiveness of vaccination. It gives you a same measure as efficacy in clinical trials. And you can see this is for the pentavalent rotavirus vaccine, RotaTech, 3-dose schedule. And the 3-dose schedule in the top row there, all the studies consistently showed very good field effectiveness that was comparable to the trial. So certainly reassuring that the vaccines are working well. What is also important to note, you look at the effectiveness of less than a full series, and there's substantial effectiveness. So I think that's encouraging news. In real world programs, sometimes children do not complete the full series. They are also likely to get good protection from a partial series. This wasn't fully looked at in trials. There were some post-hoc data. We also were able to document, as the vaccine has been used for several years, how that effectiveness is sustained over the first few years of life while children are at risk for severe rotavirus disease. And in the US, indeed, you can see there's very little reduction in effectiveness. So the vaccines certainly sustain their effectiveness over the age period. We want to see them perform well. Obviously, the key question is, are the vaccines reducing disease? And for this, we looked at data from an active surveillance platform we have in the US, where you can see we enroll children who present for treatment of severe gastroenteritis, which is the blue bars. And in the red, you can see the number that were positive for rotavirus. These are the 2 pre-vaccine years we had data for. So you can see roughly about 50% of all diarrhea admissions in these surveillance sites were caused by rotavirus, which is what we know well. And you can see, and you look at the post-vaccine data for several years now, we've seen a remarkable decline, anywhere from 60 to 90%, depending on which year you're looking at. What was particularly surprising was that first year where we had vaccine rollout, where we saw this big reduction, 85-90%. We knew that vaccine had only reached a small number of infants and 1 year olds. So why did we see such a big decline with only coverage in young infants? And also in those infants, we knew in the US our coverage wasn't great initially, only about 50-60%. So we dug a bit deeper into that data from that first post-vaccine season. And what you can see here is that same data, but it's broken down now by age group. And you can see in this column in the middle, that's the decline in rotavirus hospitalization rate. And the far right column is the vaccine coverage. What you'll notice is in that oldest age group of 2 to 3 year old children in that year, none of them had been vaccinated. The vaccine had just been introduced after they were born, and so they were ineligible to be vaccinated. But you look at the decline in rotavirus hospitalization rate in that age group, almost as much as in the directly vaccinated infants. This was our first indication of herd immunity or herd protection from the vaccine, something that really wasn't anticipated as much for rotavirus as compared to, say, pneumococcal or other vaccines, and came somewhat as a surprise, a good surprise, but nevertheless, it shows you how you can learn things that are tremendously important. We extended those observations to look at gastroenteritis hospitalizations in US in older children and young adults. And you can see there are three graphs there. The top one is for the children under 5, and then you see for the 5 to 17 age group and the 18 to 64 year age group. The line in black and the gray shades around it are the numbers that were in the pre-vaccine years, the median and the range for those, and the 12 months of the calendar year are laid out. You can see very clearly in young children, the red line, which is the post-vaccine year 2008, was substantially lower, as we saw in the previous slide, reduction in children. But what was surprising was even these older age groups where we never thought rotavirus was a problem to that extent, we had that reduction in severe gastroenteritis hospitalization. So we now know that vaccine is not only benefiting children, older unvaccinated children, but even adults and the elderly. And this is not unique to the US. We have, this is recent data from the UK where they implemented vaccine in 2013. And you can see what you see here are the reduction in gastroenteritis hospitalizations by age group. And you see the bars on the right, the two shaded, on the left, the two shaded in red are for the under 1 and 1 year age group. Those were the only age groups that had been directly vaccinated within a year or two of the rollout. But look at the declines, the numbers on the right side in those blue bars. Those are all unvaccinated age groups. In fact, for this setting in this year, 85% of the decline was from unvaccinated age groups. So if you're only thinking vaccine was benefiting vaccinated children, you would really not count that huge decline in older age groups. I think this has been one of the remarkable findings with the post-licensure experience with rotavirus vaccines. Another questions outstanding from the trials was the effect on mortality. It wasn't something that could be measured in clinical trials just because the sample sizes would have had to be enormous. So what we did was, in a setting where the vaccine was introduced nationwide in Mexico, we went and gathered their national vital statistics data. So these are data on all-cause diarrheal deaths in children under 5 years of age. And you see there are 4 years of pre-vaccine data from 2003 to 2006. And you can see there are three curves there. The red line on the top is for the under 1 age group, the blue line in the middle for the 1 to 2 year age group, and then the 2 to 5 at the bottom. What you see is that each year in Mexico, and mind you, these are not rotavirus confirmed deaths, they're all-cause diarrheal deaths, but you see these sharp seasonal peaks during the winter months, and shaded behind those peaks are the months of the year when rotavirus circulates in Mexico. So this was indirect evidence that at least a good proportion of those winter seasonal diarrheal deaths were from rotavirus. The proof really came from vaccine once it was implemented in 2007. You can see rapidly within the first year when the under one cohort had been immunized, that red line has declined appreciably. And in the second year, that under one decline is sustained, but also the blue line, the 1 year age group, which had been vaccinated, now showed this decline. So it's ecologic data, but it certainly provides very compelling evidence of the timing and the synchrony of that decline by age group, that it's a result of vaccination. So that was another very promising finding. There remain questions even after some of this initial data from high middle income countries about how well the vaccines will work in developing countries. And I think most of you appreciate for oral vaccines like rotavirus, there are many factors that could impede vaccine performance, particularly in developing country settings, and those are illustrated in this cartoon. For this reason, the vaccines were tested specifically for efficacy in trials in Africa and Asia. Shabir and Kathy, who are here, were involved in these trials and led them. And indeed, the vaccines showed a lower efficacy. And this was brought up, I think, in Brad's presentation yesterday as well. We see an efficacy in these trials of 51 to 64%, not the 85 to 98% you saw in high and middle income countries. The obvious question was, what does this mean? And I think a point that Brad probably made, I unfortunately missed his talk, but I'll re-emphasize, is the data from these trials showed that despite lower efficacy, the burden of disease prevented in these developing countries was greater. And you can actually see this by just even splitting the data from the trial of the monovalent vaccine in Africa. And you can see these are the rates of severe rotavirus gastroenteritis in the placebo arm in Malawi and South Africa, the countries. You can see Malawi is almost 2.5 times greater. The vaccine actually had a higher efficacy in South Africa, 77% compared with 50% in Malawi. But if you look at the actual number of cases prevented by vaccinating 100 children, more were prevented in Malawi. So lower efficacy, but a greater impact because of the higher baseline burden in Malawi. And I think this is a point that Brad likely made much better than I did repeatedly, but an important point to note for vaccines that are partially effective. It's not just the efficacy that matters, it's the absolute burden of disease prevented. We have, of course, now seen introductions and rollout of these vaccines in low-income countries, so it's provided opportunities to really assess impact of the vaccine in routine use. I'll show you a couple of pieces of data. First are from Rwanda, which was one of the first countries to introduce the pentavalent rotavirus vaccine in Africa. You can see here again, these are all-cause diarrheal hospitalizations reported from 27 district hospitals, and you can see, if you see preceding the vaccine introduction, those sharp winter peaks in all-cause diarrhea, and again a severe blunting after vaccine introduction. We went to 6 hospitals in Rwanda and reviewed their logbooks to look at what percent of childhood admissions were caused by diarrhea, and you can see again, before the vaccine was introduced, about 20%, 1 in 5 of all hospitalizations in children under 5 were from diarrhea. That declined very rapidly to about half of that number in the 2 post-vaccine years with available data. So again, very promising impact. And just one other finding from Botswana, where they looked at in-hospital diarrheal mortality. You can see before vaccine in the bold bar, and the 2 post-vaccine seasons immediately after vaccine introduction, about a 50% reduction in in-hospital diarrheal mortality. So again, confirmation of the mortality benefits of the vaccination program. We have done efforts to look at the economic impact of vaccination, although I must say they have not been as elegant as they could be given the nice presentations this morning. So I think there's room certainly to expand on this work. One piece of data I'll present is a study that was done in Malawi, which was actually a fairly intense study where they followed up a cohort and they obtained information both from the household societal perspective on variety of expenditures, but also from the governmental perspective on healthcare expenditures. And they estimated, based on these reductions in these cohorts and extrapolating to the country, that vaccination of children in Malawi annually averts about 54,000 cases of rotavirus gastroenteritis and 281 deaths. And they estimated, based on these costing data collected from this cohort, that the cost effectiveness of vaccination was about $19 per daily averted. I must say that's at the price that the country co-pays for Gavi purchase, so it is on the lower end of the range. They did a sensitivity analysis which showed that it was still cost effective. Just to benchmark what that $19 per daily means, if you look at the cost effectiveness of bed net programs for malaria, that's about $27 per daily. You look at the effectiveness of insecticide spraying, that's about $143 per daily. So really a very cost effectiveness intervention in this setting in Malawi. Jumping to another issue and a controversy that remained from the clinical trials was the effectiveness of these vaccines against a range of circulating strains. And just to orient you, for those who are not familiar, the two vaccines are a bit different in their construct. So you have the pentavalent rotavirus vaccine, which has 5 different reassortant strains in there. But you also have a second vaccine, which is a single human strain. And in particular for that vaccine, there were concerns of how well it will protect against non-vaccine types. And indeed, in one of the pre-licensure trials, the pivotal trial of that vaccine in Latin America, when you look at vaccine efficacy against G2P4, this is the one strain that has a mismatch of both the G and P type compared with the vaccine strain, which is G1P8. All the others have either a G1 or a P8 in them. And indeed, for that vaccine, that particular strain, the efficacy appeared to be lower, although the numbers were small and the confidence intervals were wide, but it certainly was a cause for some concern. However, when we've looked at data post-introduction, and in the same one of the countries that did that trial, Brazil, we saw, again, through post-introduction case control studies, the vaccine had very good effectiveness against G2P4 rotavirus disease. And we've extended these to other settings where you've seen strains not in the vaccine, such as G9P4. We had very good effectiveness in Mexico. And in a study in Bolivia with a range of strains with some degree of mismatch, very good effectiveness maintained across strains. So, and I think a summary of all the experience we have is both the vaccines to date have shown good protection against a range of strains, both included, not included in the vaccine. That being said, I think as we roll these vaccine out into more low-income countries, this is certainly an issue to look at, given some of the issues about underperformance in those settings and also the greater strain diversity. So we are not completely out of the woods, but I think the data so far are reasonably reassuring. Sometimes you learn things that are not good too, but those are also important to learn. I think I showed you those large trials that did not show a risk of intussusception. We've had post-licensure monitoring for intussusception as hundreds of thousands and millions of infants get vaccinated. And indeed, in such monitoring, we have found a risk of intussusception with both these vaccines. It's a low-level risk that you would not have necessarily seen even in a 70,000 infant trial, 1 to 6 cases per 100,000 vaccinated. I think the question that has come up as these risk data have been encountered is, what does it mean for public policy? And again, the value of having the benefit data is that you can put the benefit and risks side by side. And that was indeed what was done and presented to policy groups like SAGE and the national immunization bodies in these countries. And you can see for each of the 4 countries where vaccine risk was documented, we had data on vaccine benefits. So you can see in the middle column are the diarrhea hospitalizations, and in parentheses in red, the deaths prevented by the vaccine, versus on the right side are the intussusception cases and deaths that would be caused by vaccination. And you can see the numbers greatly favor the benefits of vaccination. And indeed, policymakers in countries as well as at the global level have accepted that there is a risk with these vaccines, but it's greatly outweighed by the benefits, and it's not led to any change in vaccine recommendations. I think my last slide or two, are there other things that have not been looked at? I'm sure there are, and I think this is a slide that Dick Gurant I borrowed from Dick Gurant, which shows the complex issues of enteric infections in early childhood and their longer term impacts, just as was mentioned with impact on wheezing and lung function. Diarrheal diseases, similarly, you get stunting, potentially cognitive impairment, and even long term metabolic effects. These are things that have really not been looked at in any meaningful way. I wish we had done and designed the cohort studies from the trials to do it. We did not, but certainly through post-licensure experience, there's the possibility of looking at some of these outcomes through other ways, such as case control studies, and certainly an area for more research. So I hope I've convinced you that it's worth investing in research and implementation research after implementing an intervention like rotavirus vaccines to have the full public health benefit of vaccine. We've really seen the extent of indirect benefits from these vaccines. We've documented mortality impact. We've shown the impact in low-income settings despite lower efficacy, the large public health impact, and we've seen a good range of protection against strains not included in the vaccine. And although we have documented a risk, it is clearly outweighed by the benefits in all these settings. So that is all I had to say. And I think I stayed on time.